Good evening, everyone. My name is Jeremy Shue. I'm the president of the Australian New Zealand Association for the Surgery of Trauma. I'd like to officially welcome everyone to our Trauma Grand Rounds. To start with, we acknowledge the traditional owners of the country on whose land we are individually situated and recognize the continuing connection to land, waters, and community. We also pay our respects to elders past, present, and emerging. Now mai, haere mai for our colleagues across the great body of water between us that we're now freely available to travel, as we learned today. We have the bubble. So without further ado, I'd like to ask Kate Martin to introduce our topic, as well as our speaker and the panelists that we have for this evening's Trauma Grand Rounds that I'm really looking forward to. So thanks, Kate.
Thank you very much, Jeremy, and welcome everyone to the fourth of our ANZUS Trauma Grand Rounds. Very honoured this evening to welcome our keynote presentation from Professor Mark Sheridan. Mark is the Director of Neurosurgery at Liverpool Hospital, but he's also the current Chair of the Trauma Committee of the Neurosurgical Society of Australia. Mark has been heavily involved in teaching neurosurgical skills to not only neurosurgeons, but also to us general surgeons, particularly through DSTC, which I'm honoured to say I have had the opportunity to teach with. This evening, I would also like to acknowledge again the excellent support from the College of Surgeons, in particular the Victorian Regional Office, who without their assistance, this just simply would not be possible. So thank you particularly to Shane Macy and to Catherine Walsh. So this evening we will have a keynote address delivered by Mark Sheridan, and then that will go for about 45 minutes, and then we'll have a panel discussion. We've got a group of very experienced educators, as well as mostly neurosurgeons, but we've also snuck David Reid in there again. Now, David is the Director of Trauma at the Royal Melbourne, but is also has been the Director up in Darwin for over a decade. I think it was close to 15 years. He is currently fishing out Exmouth Way, somewhere in Western Australia, but I have heard from him, so he should be joining us. Also like to welcome Dr. Ruth Mitchell. Ruth has just taken up a position at Sydney Children's Hospital. She is a neurosurgeon, and Ruth has got quite a strong interest in education and has been involved in trauma, both pre-neurosurgical training years, as well as obviously as a neurosurgeon. And then we're very honoured also to have with us tonight Professor Michael Redmond, who's the Director of Neurosurgery at the Royal Brisbane. Professor Redmond has also worked with David Reid up in Darwin, so brings to the discussion his experience working both within a major neurosurgical centre, but also in a not so major neurosurgical centre. So please do send through your questions or comments. They can be sent through at any stage using the chat function, which you'll find the button for down the bottom of your screen. Send them through at any stage during the presentation, and we'll endeavour to get to all of them, and we'll put them together into themes. So without further ado, I'd like to now welcome Professor Sheridan to deliver his presentation on managing brain trauma outside the major neurosurgical centres. Thanks, Mark.
Thanks, Jeremy, and thanks, Kate. I'll just get my screen up. So, hello everyone, I'm Mark Sheridan. I'm a neurosurgeon, as Kate said, at Liverpool Hospital. I've had experience with remote trauma surgery in my time in the Army Reserve, but also as been quite involved with incoming trauma at Liverpool Hospital, which of course is a major trauma centre. So without too much ado, here we go. So I'm going to just first present a case that I was personally involved with when I was in deployment overseas in Bougainville. For those of you who are in the Army Reserve, you recognise this place in Bougainville, Lolaho, where the Peace Monitoring Group had its base. And this is a case just for interest, and it raises a lot of issues, I think, which we'll need to go over during the course of the presentation because of its remoteness. So this is a young man who actually had a coconut tree fall on his head rather than the usual coconut. He was picked up about 24 hours after his injury by one of the patrols, and he had this open compound fracture on his head. His GCS was 14 when he was first found, and not long after, the nursing officer stitched this up to stop the ongoing bleeding. dropped his GCS to about 10. So he was medevaced back to the Lolaho base by helicopter. And you can see here the resus bay, typical Army RAP resus bay. Very limited resources there and no chance for retrieval back to Australia. And there was actually, we weren't permitted to take people back to Australia either in that particular deployment. So we're in a tent. It's very hot, very humid, very tropical. There's an anaesthetist, a general medical officer, and medics and nurses, and a dentist helping. So we had an X-ray machine to look and see whether there was a fracture there, and indeed there was a compound depressed fracture. I had no idea what was under it, but the guy's GCS was dropping, and we had to decide what to do. When you're on a deployment like this, it's very important to look at your end game. You know, the resources are limited. You can't have someone ventilated for more than 12, 24 hours because of the lack of oxygen and all the other resources, which also need to be preserved for Australian and allied personnel. So we agreed with the commander, officer commanding, that we would be able to ventilate this guy for 12 hours afterwards. And after that, we'd have to extubate and see what happens. We certainly didn't have the resources to ICP monitor him. So after a discussion and everyone agreeing what the plan was, which is very important before you start any heroic deeds, we decided to decompress this fellow and see if we could help whatever was underneath there. I presume that he had an expanding clot just on the basis of his drop in GCS. He had no other injuries. So here we are in our blue theatre scrubs, blue theatre shirts, and our lovely khaki shorts, camouflage shorts, and that's the operating table. No pins, nothing fancy. Headlights with little torches on them. This tent was air conditioned, so we weren't dripping sweat into his head, and this is us about to go. So prep, drape the usual way. We weren't worried about COVID at that stage, so the officer commanding wasn't wearing a mask. And this is what I found. So top left, I didn't have any power drills. We had to use a perforator and Gigli saw. And I excised the fracture. It was quite compounded, nasty, and been open for a few days. So you can see how I'm connecting the burr holes, which I've created for a fairly generous flap, and you can see some extradural and subdural blood sitting under there. So I evacuated him. Luckily, even though he had a significant subdural, the underlying brain injury wasn't too severe, which is very important. And again, we'll discuss this as the evening goes on. But he started off with a good GCS. So I knew his underlying brain was okay. And he was very classically having an expanding clot with a dropped GCS. So I took the clot out. I actually left the bone out at that stage. It was the thing to do in that era. And I sewed him up over a drain, didn't do anything fancy, stapled up his head. There he is the next day after he was extubated. So he very much behaved like more like an extradural, as young people do, rather than subdural. And he woke up without brain swelling. And I actually went on a second deployment later that year. And I took all the makings of a cranioplasty to repair the big dent I left in his head. And he refused to come in. He was quite happy with the dent in his head, and he didn't want us to fiddle with his head ever again. So he's wandering around the jungles of Bougainville at the moment with a large dent in the side of his head. And yeah, so a good outcome. But this raises the issue of, you know, understanding your capabilities, understanding what you can do with a patient and what you're going to do afterwards with them. So, you know, it has all the classical features of a remote craniotomy. You need to understand your capabilities and resources before you do anything, and you need to know what you're capable of yourself and what your team's capable of as well. You know, this is not something that you undertake just out of the blue with no preparation or planning or understanding. You know, you need to know before even these cases come in what you're capable of, and what your team's capable of. I was deployed there as a general surgeon, so this wasn't traumatic for me, but the next case I did was an amputation for a chap who'd had his legs hacked with a machete, who'd developed a really nasty gangrene and was dying of septic shock. Now, that was traumatic for me, not for you general surgeons and trauma surgeons, but that was a much more difficult case than this was for me. But it's the reverse, of course, when people aren't familiar with neurosurgery or haven't done time as a neurosurgical registrar. So as with everything, prior preparation and planning and forethought make a very big difference. And it's very important for your team as well, particularly when you're somewhere remote like this, that everyone understands your thinking and everyone's happy and not traumatized by what you're doing. So we'll come to the Australian experience of remote surgery. This has been a topic of interest both for the Neurosurgical Society and the trauma community in general for many years. And the way we do things and the resources, the retrieval services, even the way we communicate has changed enormously over the last couple of decades. When I started my training as a general surgical registrar, which I did quite a bit of before I went to neurosurgery, I worked in country towns where there were general surgeons who could do literally everything. At Griffith, there was one guy I worked with who did orthopedics, urology, plastics, the lot, and very capable. But the training and where people are at now is very different. And also the number of hospitals, particularly in New South Wales, I don't know what's happening in other jurisdictions, but actually have surgical services is greatly decreasing. The days of the GP general surgeon drawing to a close, if not have drawn to a close. And we're seeing subspecialty trained general surgeons in a lot of our rural hospitals, particularly our level 1, our trauma centres in the rural areas. So we go back to 2006. Bishop and Kate Drummer did a survey for the Neurosurgical Society and the ANZ College of Surgeons, looking at the trauma experience and what had happened over the previous 5 years. And they found that 90 surgeons had performed 600 neurotrauma procedures over that time. 28% of the surgeons who'd done these procedures had training above resident level. Everyone else had only seen neurosurgery when they were JMOs. All the cases, even in that time, were performed on the basis of CT scanning. They found that no one had had blind craniotomies or exploratory burr holes in that era. And they found that, amongst the other things, that the further you went away from a major neurosurgical neurotrauma centre, the more confident the surgeons were in reporting CTs. Obviously, they knew that they were in situations where they had to be experienced in managing neurotrauma. And what we're, the majority of these cases, interestingly, were done in Darwin, which of course is our classic example of how it can be done right. So the Darwin Experience, Michael and David, if you're online, know about this better than others, but it's been well documented, the pre-neurosurgery Darwin Experience and what a good job can be done with general trauma surgeons doing neurotrauma. So two main papers that reported in ANZ Journal of Surgery. The first one was looking at cases between 1992 and 2004, 258 patients, 130 craniotomies, as well as other cases. And their experience and their outcomes were very good. They were equivalent to what we would get at places like Liverpool or major trauma centres. 82% of the extradurals had a good to moderate outcome. Acute subdurals, not so good, and traumatic ICHs, intracranial hemorrhages, which are operated on, less good. So very much mirroring what you'd expect in a level 1 trauma service. And I think this is the sort of outcome we can expect in our major regional hospitals. And I think it's something we should be training people towards and helping them get these sorts of outcomes. Because in Darwin, of course, as you know, Michael, you can't get patients anywhere. It's way outside that, the so-called 1 or 2 hour window for taking out a clot that's expanding and getting patients a good outcome. So when you're remote, you just have to do it unless you've got a neurosurgeon. The second paper was done in 2008 to 2013. Again, 61 patients. They had 0% mortality for their extradurals and 33% mortality for their acute subdurals. Now, that's outstanding. And it also shows increasing experience of when to do surgery. It's very important. And what this reflects is you pick your patients right and you get much better outcomes, and you're not operating on patients who you know are going to have very poor outcomes. So again, Darwin Experience is a lesson for us, and it should be a template, I think, for what we can do in other similar remote centres with the right training, experience and support. So the current situation in New South Wales, we've just done a paper which is under being looked at by the ANZ Journal of Surgery, so for publication. So I don't know whether I'm going to get into trouble for presenting our figures before we get it published, but nevertheless, I'd like to thank Joey Youssef, who was our non-accredited registrar last year, and Nevenka Francis, who's our CNC for trauma at Liverpool, for helping us with this. Nevenka in particular, she knows the trauma system and how it works in New South Wales. And this is a reflection of how things have changed since the state trauma plan was introduced in 2009, which allowed the paramedics to bypass the small regional hospitals and take patients direct to sort of regional trauma centres. And it also activated the aeromedical and retrieval services so that they knew a patient was heading somewhere where they may need to be retrieved from. So it really provided an excellent service for particularly neurotrauma patients, that they were going to be moved quickly to the right place. What we identified in this paper is there's 149 regional and rural hospitals in New South Wales, and 56 of those have surgical services, excluding Newcastle, Wollongong and Nepean, which actually have neurosurgical services. So what we did is we contacted, the registrar contacted all these hospitals and spoke to the nursing unit managers and theatres, the director of surgery, and basically anyone he could talk to find out what's going on. The nursing unit managers were able to look in their theatre logs to see what was going on. And in so many of these places, the nurses have been there for a long time, so they knew the story of the place. So what we found out, that of those 56 centres, only 23 owned a craniotomy set. And what I mean by craniotomy set is a Hudson brace and a Gigli saw. We're not talking a full neuro tray. And then of those 23, only 16 of them stored that Gigli saw and Hudson brace sterile. I think the other ones might have been sitting in the museum, the hospital's library. And of those 16, only 13 actually had a Gigli saw. The rest of them just had Hudson brace. So not very well resourced. Some of the bigger centres, of course, had Midas Rex drills and that sort of thing, big places such as Wagga and so on. But yeah, we were mainly looking at the basic set of kit. And then we asked them what had been done, who'd used those equipment in the last 5 years and last 10 years to see what had gone on. And what we found in New South Wales in the previous 12 months, and this was up to mid last year, there had only been one craniotomy performed in any of those hospitals. In the previous 5 years, there was a further 7, and then a further, I've got the little screen on the side, a further number in the last 10 years. And what we found when we tried to trace these patients down, which was not easy, I must say, 2 of those patients had died prior to transfer. 3 patients had died after transfer, soon after arrival in the receiving hospital, and only 2 were identified as having been discharged to home. The rest of them, we couldn't actually follow up, so we don't know whether they ended up home dead or in care. So yeah, it's an interesting statement of where we are at the moment. Clearly, the number of cases in New South Wales that are being done in the regions is, I think, significantly less than what appeared in the paper that was done 15 years ago now. Things are changing, and it's due to a number of factors, both training of the surgeons, the confidence of the surgeons, and the availability of the resources to support them. And also, in a lot of places, we can get patients within that 2-hour window to a neurosurgeon, at least in New South Wales. While we have vast distances, we don't have the vast distances that you see in Western Australia, Queensland, or the Northern Territory. So I must say, this only reflects the New South Wales situation, doesn't reflect what's happening elsewhere in the country. So that's a real caveat. I can't speak for everyone else. So just to remind everyone, this is what a Hudson brace and a Gigli saw looks like. That's all you need to do a craniotomy. It's actually an extremely dangerous thing to use if you don't know what you're doing. And I don't know what Michael thinks, but pretty much no one younger than me knows how to do these. And having spoken to all my trainees, most of them have never even seen one, let alone used one. we keep ours sterile at Liverpool, and each year I bring it out to show the trainees. And when we do the DSTC course, I take ours out to use on the sawbone model to teach people how to actually use it and how to use a Gigli saw. But it's something you've really got to use beforehand to learn how to use it. You can really hurt someone badly if you don't know what you're doing, and it does take some experience and training to use it. This is what we prefer, and this is what everyone's trained on, or its equivalents. Midas Rex, high-speed pneumatic or electrical drill with a perforator, which is the big chunky thing you can see with a drill bit that allows you to drill a burr hole without actually plunging in. It's got a clutch on it that allows you to go through the inner table and then stop. And then on the other side, the left of it, you can see the craniotome, which is like a side cutting saw with a spinning blade that allows you to actually do the craniotomy, to cut the bone sideways without wrecking the underlying brain. Again, you need some training to use these. They're expensive to maintain. Everything, all the drill bits and everything expire after a short period of time, and Medtronic make an awful lot of money out of keeping stock that never gets used. But nevertheless, in a perfect situation in a centre such as Darwin, or even some of the big regional centres, this is a much preferred piece of kit than the Hudson brace and Gigli saw. But again, it requires experience and training to use it, but much easier. You can teach junior registrars to use this without fear of them hurting someone too much. So let's go through the cases and the type of pathology we see, and I'll talk you through my thinking and what the literature suggests is the right thing to do in 2021 for these sorts of cases. So the first pathology we look at in neurotrauma, and the one we like the best because it gives us the best outcomes, is the classic extradural. You can see it here, the classic lentiform shape, where the blood clot has stripped the dura from the inner table of the bone, and it's usually associated with a fracture and an arterial tear in the dura. These patients often have the classic lucid interval because they have a head injury, but they haven't got a severe underlying brain injury. They don't have that severe traumatized brain. So they wake up after their initial concussion or their knock on their head, and then as this expands, they go off. These are the patients which we must get right. These are the ones who are often younger, and we can get much better outcomes because they don't have that bad underlying brain. It's actually relatively uncommon. I just looked through our figures at Liverpool for the last 12 months. We've done 3 extradurals, acute extradurals, acutely in the last 12 months. So even at a fairly busy trauma centre like Liverpool, they're not that common. Maybe because we don't have a paediatric population. They're more common in the younger people because of the way their dura is stuck to their brain and how they get hurt. But nevertheless, they're relatively uncommon. But these are the ones that have to be done early. You've got to get them at or just after they start neurologically deteriorating and they start damaging their brain. Time is brain, as they say classically. And this is the one where you really want to get it done in under 2 hours if you want to get a good outcome. And these are the ones that you have to do away from the major neurosurgical centres, because you can save these patients' lives. And the skills that are required to do this surgery for an extradural are very teachable. If someone's an experienced general surgeon, you can do this surgery with some support and training and get very good outcomes, as we've seen in the Darwin Experience with general surgery doing this sort of stuff. So this is the thing we have to get right. And yeah, this is the one we want to fix. The next group of patients are patients with an acute subdural. Now, these are very different pathology altogether. They can behave like, say, an extradural. They can have a slowly expanding lesion without severe underlying brain injury, and they can act like an extradural with the lucid interval. They're the patients that you do want to operate and you want to get the clot out. But commonly, they've got a severe underlying brain injury. You can see in this scan the midline shift. Part of that's due to the expanding clot, but part of that is due to that brain on that side being swollen. So you've really got to think very carefully how you're going to manage these. And we've become increasingly conservative in our management of acute subdurals and very wary, particularly of the elderly with a severe underlying brain injury, with a bad GCS to start with, and particularly with multiple comorbidities. These tend to occur in older patients. They're often on blood thinners. And as we know, the newer blood thinners, which the cardiologists and the neurologists like, don't have reversals. Even though dabigatran, Pradaxa, has a reversal agent, I haven't seen someone on Pradaxa for such a long time, even though we keep this stuff in the fridge at the hospital at vast expense. They seem to be all on Xarelto because Pradaxa has issues with kidneys and dosage. So every patient we see coming in with the subdurals on Xarelto, and it's a disaster. You just don't want to operate on those. The patients obviously have more other comorbidities. They have a severe underlying brain injury often, and their outcomes are really bad. And the other paradox with these, there's the so-called early surgery paradox. Patients who have acute surgery for these actually have a worse outcome than patients who have a delayed surgery, often because they're sick, they're multi-trauma patients, they've got a worse GCS to start with. So clearly they're got an underlying brain injury that's going to give them a bad outcome. Patients who deteriorate a little bit down the track or who turn into a chronic subdural actually end up with much better outcomes. Again, probably because of the underlying brain injury and comorbidities and other trauma not being as bad. And the surgery is more difficult. This is the one where you get a phone call at 3 a.m. in the morning because the registrar's taken the theatre and got themselves into a big mess because of bleeding, venous bleeding they can't find, sinus bleeding, brain swelling. They can be horrid operations, and people who don't know what they're doing in terms of hemostasis, which is often the most difficult bit in neurosurgery, can make a bad situation worse. So you've got to be a lot more experienced in doing one of these and be a lot more confident than you would with doing an extradural. And these are the ones where you really want to be talking to someone about, are you doing the right thing, understanding the patient's wishes and understanding the family's wishes, because you can save someone's life by taking the clot out, but in an elderly person, you can almost guarantee that they're not going to get back to their pre-morbid level of functioning. And a lot of people have strong views about whether they want to have surgery in that situation. So much more difficult, but there are the patients who you will want to do because, again, they've started off with a good GCS, don't have a bad underlying brain injury, and you can give them a similar outcome to an extradural, but you've got to know the difference. Next group of patients are patients with a diffuse injury, ranging from just a diffuse axonal injury where they're in coma, their GCS is 8 or less, but their brain scan can look absolutely normal, through to contusions, which is, these essentially a bruised brain, which can be coup, contra coup, and have all sorts of patterns depending on the mechanism of injury and the speed and so on, right on to full intracranial hemorrhage with an expanding intracerebral clot. So these are a much more difficult situation. There's a recent trial, well, not so recent trial now, called the Stitch 1 trial, which looked at the surgery of acute traumatic intracerebral hemorrhage. And it's basically, it didn't show much work for these at all. While they said that, GCS of 8 or less, there's no advantage of surgery and you shouldn't be taking the clots out. They suggested that patients 8 to 13, yeah, you could take the clot out, but I don't know whether I'd be taking clot out with someone with GCS of 13 for a bunch of reasons. And these patients with diffuse axonal injuries, raised intracranial pressure and diffuse brain injury really are best managed with medical management. And these are per the Brain Trauma Foundation guidelines, which I'll go into in a sec. So Brain Trauma Foundation guidelines, there's the website. There's a 4th edition, which has just been updated based on some recent proper multi-center trials. The 4th edition ones to look at. And it's very useful. It actually looks at the evidence for everything we do in the management of brain injury, traumatic brain injury. So it looks at everything from your ventilation, your CO2 settings, the use of hyperosmolar agents, ICP monitoring. They're a good read. And interestingly, as more and more evidence comes in, a lot of the things that we used to believe strongly in have really shown to be either not useful or actually bad. Their only level 1 guideline, interestingly, we have in brain trauma is that steroids are actually bad for you. The rest of it's level 2A, 2B, or 3, and they discuss this at quite some length. It comes down essentially to good basic EMST, ATLS management. You get all that ABC stuff right, you're really following the guidelines. And you've really got to get that stuff right before you get on to doing heroic surgery, of course. There are guidelines in the Brain Tumour Foundation website for surgical management. They're rather out of date. They date back to 2006, and they certainly recommend some things that we wouldn't be doing now. So not so useful, but still a good read. So treatment options, the most important things before we do anything surgical, even though we're surgeons, we like to surge, is the medical management. We have to get all this stuff right before we go on to doing an extradural, subdural, something else. So you've got to treat the other problems first. You've got to go through your ABCs. You've got to establish an airway. You know, you've got to get the oxygen into them. But you want to aim for everything being normal. You don't want hypercapnia. You don't want hypothermia. You want normal blood pressure, normal oxygen, normal CO2. You want to get into your C and stop your bleeding. There's no point me doing a heroic, wonderful craniotomy if the patient's bleeding to death from, you know, chopped off leg or something bad going on in their tummy. So you've got to sort your C stuff out. And then I'm D, you know, where neurosurgery is D. So you've got to get all your ABC stuff right. ICP management in a rural or remote setting, unless you're somewhere like Darwin or somewhere that's very remote, it's really not a topic for this sort of talk. It's interesting, there's increasing discussion about the value of ICP management and CPP management as well. And a lot of discussion saying it's not so much getting the CPP or the ICP right, is by monitoring those things, you're monitoring everything else with the patient right. And our slavish attempts to get, say, cerebral perfusion pressure right by pushing people's blood pressure up turns out to have probably been counterproductive and causing more problems than it did good. In terms of CT, really in a surgical setting, you know, when you're not doing burr holes out in the bush, we really want to be guiding our management with CT. The days of the exploratory burr hole, I think, are long gone, and I've done it in sort of very difficult settings, but it's really not something an amateur wants to do. You can miss the clot, you can get yourself into all sorts of trouble, and you know, most places that have a surgeon and a theatre now has a CT, and you really should be guiding your management from that. And then you've also, right from the very beginning, got to plan where this patient's going to go. Like I discussed in the Bougainville case I presented at the beginning, you need to determine you know, what you're going to do with this patient, whether you've got the capabilities to look after it in your ICU and whether that's the right place for it to be, or whether you need to start mobilising all the resources to get this patient retrieved to your definitive trauma centre. It's different from every jurisdiction and every state, but you've got to be planning for that almost from the minute the patient comes into your resus bay. In terms of secondary decompressive craniectomy, this is an area of some controversy in neurosurgery, although with the now the Rescue ICP trial and possibly the results of the Rescue ASDH Acute Subdural Hematoma trial, as well as with DECRA, I think the issue's been put to bed. Essentially, we don't do decompressive craniectomies now. The patients may have a better survival outcome. You may get them out of your ICU a little bit earlier, but their actual morbidity, their actual outcome, neurological outcome is worse. So you're actually making worse survivors, which is, in my view, the worst possible outcome you can have in a neurosurgical patient. So basically, we don't do it. And we used to, with acute subdurals, do effectively a decompressive craniectomy to manage the brain swelling. This trial's finished recruiting and is going to be published in the very near future, this Rescue ASDH trial. And speaking to the people in Cambridge, I suspect it's going to come out with a very similar outcome to Rescue ICP with some very specific exceptions. So yeah, we don't do decompressive craniectomies now, and my neurosurgical colleagues can debate this at the end. We'll talk about that. So in conclusion, you know, I'm talking about the New South Wales experience and what's been published in other states. Now, I know every state's different, every jurisdiction's different in terms of what you've got available and the tyranny of distance we have everywhere in Australia. But I certainly think there's a role for the remote general surgeon to be able to do at least an extradural and probably some of the appropriate subdurals. But you know, the person doing this in the middle of the night without backup, without support of a neurosurgeon, without really having other people involved is long gone. We all have mobile phones, we all have cameras on them. We can Zoom, we can Skype, we can really get support right from the very beginning. And I think we should do that. Even when we're on deployment overseas with the ADF, we can get support. I've had phone calls from some very strange places around the world from ADF general surgeons seeking support and guidance and talking them through procedures. So you've really got to have that phone a friend ability. And I think it's very important. We need to train people, and the start of it's DSTC, but I think it's very important for people who are really going to be at the coalface of remote trauma, really need some time with a neurosurgeon. And you can learn how to do a craniotomy and manage the bleeding with the craniotomies we do with tumours. That's a really good way of just getting a feel for the equipment, getting a feel to how to handle bleeding on a brain. The actual neurotrauma requiring surgeries increasingly uncommon places like Liverpool. From the 23 years I've been there, we've gone from doing big open neurotrauma craniotomies to really doing a lot of ICP monitoring and not much in the way of craniotomies. And I think it's going to be a problem for us in the future as the way we do things changes, that the young neurosurgeon is going to have trouble getting experience in a lot of these cases, particularly if they're not at a centre like Liverpool, which is a designated trauma centres. Some of our big hospitals that are trauma centres aren't seeing a lot of trauma. So we need the resources in terms of equipment. You need to know the equipment's there. You need to know how to use it. The nurses need to know where it is. It has to be sterile. All the prior preparation and planning that we know about. And I can just say, I really do not think there's a role for the so-called bush burr hole. I know we've got all the anecdotes and everyone has a story about the Black & Decker out in the field at the back of a ute, but I don't think that's the way to do things. When I teach DSTC or talk about an EMST, I basically say that, if you've got an extradural and you've got a Black & Decker and a 5 mil hole, it's a bit like sucking a placenta up a straw. It's not going to happen. There is a case report in the UK of someone using a intraosseous needle to go through a skull and suck out an extradural, which I think is crazily heroic and amazing. But I don't think I'd be advocating that as a valid and transferable surgical technique. So I think that's enough of you listening to me talk. Shall we open up the floor for some questions, Kate?
That's a brilliant idea. Thank you very much, Mark. That was a really great little sort of trip along the pathway of what's actually involved in treating these patients, and thank you very much for that. So I do encourage everybody to put some questions in the chat. I will start with, I'm going to hand over to Ruth Mitchell, just more with a comment, and that is with regards to the Hudson brace. It'll be interesting to hear what she has to say. I was actually not allowed to use Midas Rex until I had mastered the Hudson brace back in the days, which it was almost last millennium actually. So Ruth, I might hand over to you, and if you've got a comment there to make with regards to the Hudson brace.
Yes, thank you, Professor Sheridan. That was a fantastic overview, and I think really sets us up well for some great discussion. And I think thinking about my reflections on my own neurosurgical training, which finished not that long ago, I'm grateful that in 2 different institutions, I had bosses who said, this is a Hudson brace and you're going to use it for this craniotomy. And handed it to me and showed me how to use it. And I think that now that I'm someone who is teaching other people, is something I would like to be able to do. Locate the Hudson brace, make sure it stays sterile, and make sure that each trainee gets a chance to see what it does. And I think there are some simple technical tips that will help to make that safer. And one of them is just very simple points, such as making sure that you hold the Hudson brace in such a way that the drill bit is facing upwards so it doesn't fall out and onto the ground because there's no backup. So just those very simple technical things. If you haven't held it in your hands before, you don't realize that dropping part of it on the floor is a real problem, and that's not something you want to find out the hard way. And so I think that having used the Hudson brace and a Gigli saw first on a cadaver and then on a human carefully supervised during training has been a real asset for me. And it's not something I've done a lot of, but I think when I think about when I'm likely to need that skill set, it's most likely to be the case that that'd be when a rural general surgeon calls me for advice. And then at least I can say to them, well, look, this is how this gear works. And so I think that there's value in making sure that all of our trainees actually see the kit and know if you've got it and know where to put it and how to use it. And that doesn't need to be a core competency, but if you've got one and you've got the right opportunity to teach it, I think that's really handy. That was just my reflection on that particular piece of apparatus. One other quick comment is that when I was a resident at the Alfred, the same year that I was Kate's resident, I did my first neurosurgery term as a doctor, and I remember being in the operating theatre as the resident assisting, while two of my registrars had two different perforators doing a big, huge bifrontal decompressive cranie, and this was before DECRA came out. And I think how different my registrar years would have been if DECRA's outcome had been different. I would have spent so many nights taking people's lids off in a way that I did plenty of middle of the night operating, but it would have changed the game. So I think it's really interesting how much these trials change practice and have changed what my whole training was like.
Kate, can I just say there's a caveat to my talk too, is that this is adult neurotrauma. There's a completely separate set of guidelines on pediatric management, and I haven't covered that, so just be aware.
Thank you for that. So I'm going to hand over to Jeremy now, who might want to ask the next question.
Yeah, again, thank you, Mark, for that talk. It's fantastic. It's good to see that the air getting to the brain and the blood getting the air to the brain is important aspects to it. So I do like seeing that. As I have to remind all of our trainees and fellows of that, stop the bleeding first, and then you'll help the brain. But there was a question, and this is actually something that I think gets to the heart of it, especially like our practices in Australia, and I'd be interested in all of the panel's response to it, because there's a question about what the definition of remote is, because there's obviously a time dependent relationship and outcome when it comes to intracranial bleeding, traumatic brain injury. And it's certainly one of those things, in addition to that definition of remote, certainly one of the KPIs that is generally being used is that it's a decompression within 4 hours, like from the time of injury. Now, what does the panel think about what the ideal time is to decompression? Because I guess, number one, some centers may not be able to get a neurosurgical case, within a particular time, depending on what you say. And certainly even within a metropolitan city, transfers between hospitals often take several hours. I can certainly speak in our own region in Western Sydney. To get from Blacktown to Westmead can sometimes take upwards of 3-4 hours, right? And then we're talking regional areas and the time to take to transfer patients there. So what is the definition of remote, and what is really the ideal time, for the management of these, surgical management of these traumatic brain injuries?
So the Neurosurgical Society of Australia guidelines say 2 hours. That's aspirational, but as you say, 2 hours can be 2 hours in the city, and certainly if the helicopter can't get somewhere because of rain, weather, whatever, Campbelltown to Liverpool can be that sort of, particularly if you've got to go by road at peak hour. So, we have on occasion actually got in the ambulance and gone ourselves to Campbelltown Hospital, for example, in my district, or patients turned up at Bankstown, had a scan, we've seen the clot, and rather than going through the whole resus again in our ED, they've come straight off the ambulance, straight to theatres. So it really is situational. And it's different from patient to patient. A kid who's dropped his GCS from 13 to 8 in front of your eyes, and that kid needs doing. You need to consider either going there to do it yourself if you're somewhere remote, or somewhere remote from you, or you're going to end up with a donor rather than someone who's going to get a good outcome. So it really is situational. And again, this is why we need to teach these really time critical cases like extradurals. People have to be capable of doing them.
Thanks, Mark. I'd like to ask David a question. David Reed, welcome. I hope you've caught a big fish, or that you will catch a big fish at some stage, Sonny Exmouth. As a general surgeon who has been involved in managing patients with traumatic brain injury and having to do the craniotomy, the odd craniotomy here or there, what did you find were the most useful aspects of your training in order to prepare you for that? And then did you modify that over the years? I mean, you spent a fair bit of time up in Darwin. I think it was nearly 15 years. So what are the key aspects that allowed you to be able to care for those patients and get the outcomes which Mark presented earlier, which are fantastic?
Thanks, Kate. Well, firstly, I trained in a time where we all did neurosurgery, thoracics, etc., in basic training. So I did 3 months of neurosurgery in basic surgical training, and for half the time the registrar was off sitting his exams, so I was the registrar. So that was in no way a planned thing, but was very useful. When I got to Darwin, there was very much a culture of the older guys taking through the younger guys, or in their first few neurotrauma cases, but still it was set up in a way that you'd almost behave as a neurosurgical registrar. You wouldn't take on a case without speaking to usually one of the Adelaide neurosurgeons before going ahead. As much as you need to cut well to get well, you need to choose well even more so, particularly in neurosurgery. And I'm having a good relationship with a few neurosurgeons who know your capabilities was good. Elimination of the neurosurgical registrar from the decision-making process is paramount. They don't get it. You're a consultant general surgeon. You speak to a consultant neurosurgeon. You have it at a high level, and you don't waste time going to intermediaries, either your registrar or the neurosurgeon's registrar. And it was also predicated on that when the neurosurgeons would come up to do elective clinics, because there was still a need for that, we'd go through a couple of months cases and work out what went well and what didn't go well. So there was a continuous feedback with an audit loop. So as Mark's alluded to, it's actually quite a mature response to a difficult problem. But having said that, it had to be something like that because there was the population wasn't insufficient to support a neurosurgeon, and nobody's going to argue that Darwin is not remote. It gets a bit trickier with what's remote, as you can see from Ian Sybil's questions. With what about Albury Wodonga? You're going to be able to get someone down in within 3 or 4 hours to get a decompression from them. I'd like to have a look at the timings. To be honest, I think you might get some surprises there.
Jeremy's going to ask the next question.
Yeah, we've got, there's a question, I guess it's also about training and the complexity of the craniotomies or craniectomies to decompress intracranial bleeding. But how many craniectomies or craniotomies does a new trainee kind of have to be supervised through before they're kind of allowed to be, or that they're confident enough to be independent? I know that sounds like, it's probably a length anywhere there, but I guess I interpret that question as something about the overall complexity of the operation. Like, is it something that a trainee can pick up relatively quickly? Is it something that you have to take them through multiple times, supervise them directly? Are there lots of pitfalls within that procedure?
Can I answer that?
Yeah.
We're not talking about training a trainee. We're training trained surgeons, and we're talking about DSTC level people. So this is someone who has surgical skills. They know how to stop a bleeding, they know how to cut, they know how to sew. So the actual skills you need to teach a trained general surgeon aren't that many to be able to do a craniotomy. rudely, I would say that you could teach a monkey how to do trauma neurosurgery. That's what I tell my registrars, but that not anymore, of course, after our operating with respect. I'd never say anything like that now. But the actual skills are not that difficult. The most difficult skill to teach someone in neurosurgery is decision making. You know, the extra couple of skills you need to get into someone's head and take out a clot and stop the bleeding, it's within the realm of what any general surgeon with an FRACS could do. So it's not a big deal. No, we have all this mystique with neurosurgery, but yeah, it's skills that any of you guys can learn.
Michael, do you have any comments on that in terms of training? And is it something then do you agree with Mark about, you know, that it's something that, you know, particular, I guess, our regional surgeons, you know, maybe have seen it on YouTube? I don't know.
Mark's made a great point there. These are not neophytes. These people have got well-developed manual dexterity skills, and it's just a matter of transferring those skills to a new environment. I think that really, as far as Queensland is concerned, we still are having issues with people dying in regional hospitals or dying after delayed transit when they could have been aided by surgery on location. So it's really a matter of just educating the local surgeons to have ownership of these patients when they come in, and for them to be able to develop the confidence to make that difficult decision to proceed. And I don't think it would take a lot of instruction for them to make that leap, particularly after the various courses that will be available. The definitive trauma surgery course and the course that you're organising for later on in the year in Queensland. So I think, but it does mean that we have to make an effort. We have to make an effort to make these courses available, and we have to make an effort to reach out to them and instruct them in the use of the equipment and etc. So I think it's very important. As I said, we've had a couple of people lost recently, but we did have one very good save. A general surgeon opened up the head of a patient in Gladstone earlier this year and saved a life. The patient, it wasn't what you'd call glamorous surgery, but it was extremely effective and definitely saved a life in the case of an extradural hemorrhage. So it is important. We have a unit in Townsville, and then the next unit is the Royal Brisbane. So these are vast distances, and there's no way that these patients can be transferred in 2 hours. So the location is important. The context of where these people arrive for help is important. And if they arrive in a place like Rockhampton, there really must be some kind of facility. And I admire the work that Mark has done to look at the New South Wales system to see how well or not so well the regional hospitals are set up to do an emergency craniotomy. It's quite revealing. We haven't done that here, but I think it would be very instructive for us to do so.
Yeah, it's great. I mean, on that, I guess I just wanted to, and it's related to this, because I wanted to get all of your thoughts then about how do you think we should be training or enabling, you know, regional surgeons to, you know, be competent in this procedure? Is it, you know, these workshops that you alluded to that we put on, you know, like they go to it once every few years? Is there a role for telemedicine, you know, like as in having your referral neurosurgeon available on video in person talking you through it? I mean, is it something like that? Is it a regular sort of online training thing? Like what do you think the best way of actually giving people, number one, the skills, and then number two, the confidence to be able to carry out these procedures if required? Because it's not going to be very common.
No.
I think using a kind of a competency framework, like if you think about the surgical education principle at work here, you know, every learner is at a different place. And so you have to start from acknowledging that. And the original question was from a neurosurgery trainee. And I think that in that context, we know that, you know, everybody starts training with a different amount of experience under their belt, and that every learner has a different pace of picking up technical skills. And learning how to do these procedures is only one of the skills you're accruing through training. So you do craniotomies for other things if you're a neurosurgery trainee. If you're a general surgeon learning to do emergency maneuvers for other procedures, I think it starts from what your experience is and how general your original training was. I mean, people who trained in general surgery a long time ago are actually better placed, really, in that regard. And so I think that having a competency-based lens for this, which means that we acknowledge that people start with a certain level of competence and that they can accrue further competence, and that it actually does need to be assessed and refreshed from time to time. I think we probably don't do enough in surgery and using telemedicine for these things. I'm aware of a number of my pediatric neurosurgical colleagues getting, you know, expert help from overseas surgeons for very rare conditions, and that's something that's increasingly being done using, you know, really wonderful, you know, in the operating theatre telemedicine solutions to help with difficult things. One of the things that I think would be fantastic is if we had the infrastructure to make sure that we could always sort of zoom into someone else's operating theatre if they really needed us. And I'm mindful as well, another comment, I'm glad that someone's mentioned North Queensland. Last month, the month before last, spent some time locuming in Townsville. And while I was there, you know, you first of all get a sense of the geography and the distances, but the other thing that you realize is that I can get a kid from Mount Isa to Townsville in not very many, you know, hours if I say they need to get there time critical, until there's a cyclone. And there was a cyclone watch while I was up there. And I realized that if there was someone with a blown pupil in Cairns, they probably weren't going to make it to Townsville, you know, and maybe they weren't going to make it anyway. But the weather conditions, and we live in Australia and we need to pay attention to that, means that our capacity needs to be flexible. And the more people that have the ability and they're empowered, appropriately empowered to come to the rescue of a difficult sick patient, I think the better. And we've all got a role to play in that.
David's got his hand up, wants to make a comment too. Go for it, David.
Yeah, just a quick one. Whatever solution, the drilling is the easy bit. The decision making is the stuff that I've lost, even with assistance, I've lost nights of sleep over. So it won't just be about the technical aspects, help with the decision making. And the second comment is whatever solution you come up with, it's got to be repeated and recurrent. You can't just expect someone to do a course and then you're right, because they might not do it for 15 years.
Thanks, David. I've got a question which I might direct to Professor Redmond to begin with, but then open it up to the rest of the panel. There's been a comment from Ian Civil with regards to institutional capability, so that we're not talking about just the capability of a single surgeon, but really the whole group around them. I'm just wondering, Michael, whether or not you can make comment on who else, if we're going to design any courses to teach rural and remote, predominantly general surgeons on how to manage these patients, are there other staff members, theatre staff, theatre nursing staff, for example, that we should be including in this training at the same time? It's still on mute.
I think that's a very insightful comment that's been made. Yeah, so in Darwin, there was not only David Reed, there was Phil Carson, Dan Campbell, Paddy Bade, and together they worked as a team. They had a special roster, a neurosurgery roster, which was quite separate from the general surgery roster. And so I think that exemplifies how you can't just have one person on the roster in, say, Rockhampton Hospital and expect them to be available at the drop of a hat to come in and do the trauma case once in a blue moon. So that institutional capability needs to be built. I think that really has to be factored in to when we talk about training staff in different hospitals. I think that the nursing staff, whilst important, I think that it's less important that they be trained up to do the neurosurgery things, because you can't potentially get everybody up to that skill level. I see Ian's just commented on the role of anaesthetists and how important they are, and I think that's a very good point also. Do they have the capacity? Once again, in Darwin, when I went there in March of 2017, one of the really important things that I noted there was that the intensive care was well established for the management of patients with head injuries and for treatment of raised intracranial pressure. And that certainly made life much easier. And having people who are on site, like anaesthetists, who have that capacity to give the medical, to help with the medical, non-surgical care of craniotomies is really important.
I think it's Marky, yeah. I think it's very important that you have your team along for the ride. Having done remote surgery out of my comfort zone while I've been on deployment, you really need to have everyone along with you. It's all heroic and wonderful and high fives if things go well, but you've got to look after yourself and your team if things go bad. And you don't want a whole bunch of what ifs and maybes and stuff like that if things go bad. You've got to have your own, you have to be supported in yourself, to have a neurosurgeon at the other end of the line to say, yes, you made the right decision, well done, sure the outcome was bad, but you did your best. So you don't have those sleepless nights. And the rest of your team needs to know your capabilities and what you're thinking and have a realistic expectation of the outcome, because the outcomes in neurotrauma can be truly awful. So it's very important you have everyone along. And I think David really mentioned that as well, having that team there with you. In neurosurgery, there was, in Wollongong for many years, there was a neurosurgeon who practiced on his own, and that just wasn't healthy. With all due respects to Pete, it's just not a good way to be. And, you need to have a bunch of people with you, the other surgeons in your unit as well as intensivists and anaesthetists along for the ride. Very, very important. You've got to look after yourself and your team.
I guess then, just to expand on the concept of team and the team around you, we all know how to use our mobile phones and call for help when we are out of our comfort zone. I'm just wondering if, maybe start with you, Mark, too, is the value in a sort of more establishing a more formal relationship from those out of metropolitan centres, the bigger rural and remote centres, and formalising it rather than it just being my go-to person all the time, so that those links are set up and established, because there's eventually going to be a transfer. But also it would be important, I would expect, for the decision making and not to take a patient to theatre and to potentially palliate someone close to home rather than transfer them away from home only to die. So I'm wondering if you could make a comment on what you think works best, calling someone you went to uni with and you teach DSTC with, or keeping it sort of linked in with our local regional hospitals that we're going to send our patients to.
Sadly, I think having a bureaucracy around it's not a good thing. You call up the neurosurgeon of the day, someone you've never met before who doesn't know you, just isn't going to fill you with joy. You've got to have a personal relationship in this decision-making process. I need to know what you're capable of. You need to know what, that I'm going to support you. If the shit hits the fan and we end up in the coroner's court or RCAs or all sorts of dreadful things that happen, it has to be a personal relationship. And I think by having these courses, DSTC, the trauma courses and everything, you're going to build those relationships. And really, a neurosurgeon who, you're not going to get a million calls. A neurosurgeon who is approachable and understands your situation is worth a mint. You've got to have that personal relationship, and we need to build it up over time.
Thank you. And I guess just for our audience too, who's online, I think the skills training has been referred to. ANZUS have run the ABSET course, Anatomical Based Surgical Exposures in Trauma course, for a couple of years now. We're looking to run an associated rural neurosurgical skills course in conjunction with that, so a cadaver-based course. So that will be all advertised out to our members and on our website as well. And I will certainly put on the website that if you want to send through your expression of interest, if this is something that would suit you. But we're aiming to run a pilot of that in Brisbane later in the year in conjunction with ABSET. So that's what that reference has been to. I was wondering, Jeremy, if you had any further questions that you wanted to ask.
Yeah, I just I had a question again related to the regional management of these injuries, in that we looked at a little project looking at our neurosurgical referrals from Orange in New South Wales to Westmead. And it was interesting because about a quarter of those neurosurgical or injuries that were referred and that were transferred to Westmead with a head injury, only a quarter of them actually ended up with surgical management, right, for that. Which meant that there's quite a number that led us to ask the question about, well, what's the reason for getting them down? Like, as in, why are we having them at Westmead if only a quarter of them are getting operated on? And this is different to, I'll give you in contrast to, say, for example, the complex pelvis injuries that were sent to us, again, from a regional center, where upwards of 80, 90% of them ended up with an operation, right? So I guess my question is, and the reason why I said is that patients were sent down, not necessarily because they needed an operation, but because they needed to be observed for a potential operation. How do you determine which of those patients need to be observed? Is it okay for them to be managed? And should we be, from a system perspective, training up the regional centers in that sort of that low incidence case of deterioration? Or should we be, as is what's happening now, a lot of these patients are getting transferred to the major trauma centers just in case they deteriorate? Like, where is the sweet spot, like, for the efficient system management of these patients versus what's ultimately safe as well? Ruth, you had the, yeah.
Having been a neurosurgery registrar at Westmead Hospital for 2 years, I have many recollections of accepting patients from Orange Base Hospital. And I think there are many dynamics there that we've really got to talk about. And one of them is, if I get a call from a regional center that says, I have a patient I am worried about, I am not trained to say no. I am trained to say, I will make a bed. We will look after them for you. That is our job. And so I think to say no to a request for a transfer of a traumatically, brain injured patient, that runs against our training. Now, is our training appropriate? Are we using trauma centers properly? I think as a neurosurgeon that doing operations is only one part of my job. I mean, it's the best part of my job, but it's not the only part of my job. And I think that particularly with the head injury patients, there's a lot of nuance to how they get looked after. And a lot of that isn't the neurosurgeon or the neurosurgery team. It's the rest of the system. It's the fact that they're in an appropriate critical care environment, that they've got expert nursing care, that people know what to look for, people know how to appreciate if there's been a deterioration. There's often nuances around things like, sodium going off, all that sort of stuff, seizure management, which is part of what we do. It's part of our craft. And maybe it's not the glamorous part, but it's really important. And it's part of the evidence-based sort of landscape of why we get patients to have better outcomes. And so I think we need to be careful that we don't get to a place where we say, oh, we need to have people in centers with neurosurgeons only because they need a neurosurgical operation. I don't think that's the current function of a neurosurgery service, a trauma neurosurgery service. Now, maybe it will be in the future, and it is certainly in some centers, certainly in the UK, where I did an elective during medical school. They didn't get a lot of patients transferred in unless they needed the craniotomy. But the model that we have in this country, and I've worked in 4 different states now, we accept patients who are sick. And if they need an operation, that's part of it, but it's not the main meal.
I find paradoxically that, you know, the hospitals closest to me want to send the patient to a GCS 13 and they're worried because no one's going to accept the care. Whereas the hospitals that are furthest away from me send the sicker patients. They're happy to manage a GCS 13 or prolonged PTA, and they've got the resources and they just know how to look after the patients. So, and you just can't say no. You know, you get the bed managers calling you up at 3 o'clock in the morning saying, you're joking, you don't really want this patient in Liverpool. And I said, well, I'm not going to say no, and you're not going to say no. So let's just get on with it.
Michael, did you have any comments about that, about patients being managed regional versus accepting all the transfers? Can they be managed in a better way? I'll have to get you off mute. I think you're still on mute.
Yeah, there I go again. You're looking at systems, and systems. We always are challenged to improve them. And with the figures that you explained from Orange to Westmead, it's not a great look, and I guess it could be improved. But there are really strong pressures from the referring source because of their sense of being overwhelmed by anxiety about that case. And there's this pressure about their exposure to liability. And they don't want to carry that. They want to be able to go home and go to bed and have a good night's sleep, knowing that they've done the best thing for their patient. And I think that's really where the core of the issue is. And unless the education of these people can be upgraded to give them the confidence to manage them on site, then they're going to want to send them away to where the patient will be safe and where they will be safe also. That's the challenge.
Yeah. David, I might get your thoughts on it, having been in a centre where there is not really a place to send people to, and you don't have necessarily full neurosurgical services, but then also now being in a centre where you're receiving, referrals from regional areas and calls about transfers from regional areas. Like, what's your perspective on it? Because I think what Michael said is actually really relevant. A lot of it is about, that kind of feeling that you want to do the best for the patient. They're best managed in a major trauma centre.
Yeah, it's a tricky one. It's been shown that from the Darwin experience that reasonable results can be achieved, but let me tell you from experience, when you do have a bad result, suddenly you're a mug punter general surgeon in the eyes of the law, and even though you do have neurosurgical colleagues that will try and back you up, you do feel and the eyes are on you. That why did you take this on? So I feel I understand the need to move people on, but clearly if there's enough training and probably experience, then a lot of people that we routinely transfer to a trauma centre could be managed regionally. And I think it's the easy way is just to move them. It's not thinking hard enough, I reckon, because a lot of people would prefer to be managed locally at home. And there are papers out saying that even if it involves just a slightly higher risk or a poorer outcome, a lot of people would prefer to be managed in a local region rather than move to the big centre. Now, someone who's on the end of the phone saying, receiving now, if you want to send them, I will have them, but I look forward to the day that you say, you ring me up and say, I'm happy to manage this patient here, but I just want to run this by you. I think that's the next evolution that I hope is not too far away.
Yeah, I mean, just to add to that, that comment, actually, we almost see, because from the same data that we had, about 50% of the head, or what we would classify as moderate to severe head injury, so head AIS greater than 3, that came from Orange, about half of them actually remained at Orange and were managed there. So it was kind of interesting. Half of them half of the injuries were managed at Orange, half of them were sent to Westmead, and a quarter of those that were sent to Westmead actually received an operation. So they are managing them. And that's why I guess that question about, can we improve the system overall? But I agree. I think, Ruth, as a general principle, we certainly agree with that whole thing, that certainly from a major trauma center perspective, that's where we are at. And that's what we are there to do. So to help people, with that. So really, I agree with that sentiment.
The other end of the trauma spectrum actually provides a good example of how we can do it right and how the system can do it right, is the DEAD patients, or, GCS3 fixed dilated pupil patients. I often get a call, not often, I get a call from the medical retrieval unit saying, we've been called to Barrel, for example, something like that, to retrieve a patient, 83-year-old on blood thinners, GCS3, fixed dilated pupils, and they want us to transfer it to Liverpool. And the retrieval people don't want to move that patient. They know what the outcome is. We know what the outcome is. But, getting the local doctors on board to be comfortable to say, yes, this patient's dead. We can talk to the family. We can have the right discussions. We've got the backup from the big hospital, and do the right thing by not transferring that patient to Liverpool. And we can do it really well with that sort of teleconference. They can get all parties online so that the local doctors can have a discussion and everyone's happy. And you don't have this horrible outcome where some very sick old person comes to Liverpool, all the family have to trot down. You've got to get the all the stuff that goes with it. So we can do it right. The system's there to do it right. And it comes back to David's comment of consultant to consultant discussions. This is not the sort of discussion registrars should be having. It should be the bosses should all be involved in this chat. And you can, really give people confidence to look after patients which they know and can be looked after well locally.
Thank you very much. And they're absolutely wise words. So we don't have any other questions on the chat function. So I would like to take this opportunity to once again thank our panel members as well as our keynote speaker. So Professor Sheridan, thank you very much. David Reed, thank you very much. And Professor Redmond, thank you again. And Dr. Mitchell has dropped off, but she's going to try to log back on. She's got some internet issues. Thank you very much once again for your time and your insights today. I think we are at a great place with surgical skills training in trauma. So I'm certainly looking forward to the future where we can help our more rural and remote surgeons feel more confident in being able to manage our severely injured patients, particularly those with head injury, and have that confidence to get them to make the decisions that are required and give them the technical skills. So once again, I'd like to thank everybody. I am just going to share my screen again, though, if that's okay. Oh, I think I'm not screen sharing. Hang on a tick. There we go. So just for everybody out there, we thank you very much again for joining us this evening. Just keeping an eye on the numbers. It looks like pretty much everybody stayed online, which was good. If you'd like to know a little bit more about ANZUS, you can visit our website at anzus.org and see what's involved in membership there. Your feedback is really important to us, though, so you will be sent a very short survey at the conclusion of tonight's webinar. Please, it will take you less than 5 minutes to complete that. If you could complete that survey, it's great. We do use it to plan for future events, so it is important. Our next webinar, we hold these webinars on the first Tuesday of every second month, so all of the even months of the year. Joe Dawson, who is one of our ANZUS members, he's actually the secretary of ANZUS. He's a general vascular and trauma surgeon at the Royal Adelaide. He's going to talk about junctional trauma and in particular those hard to get to injuries and how to diagnose and manage them. So I thank you all again for your attendance tonight. Please stay safe and we will see you all online in a couple of months. Goodbye.
Thanks.
Thank you and bye.
Thanks, guys.